Welcome to Rural Health Today. I'm JJ Hodshire, President and Chief Executive Officer of Hillsdale Hospital, and this is a podcast where we connect you, the listener, to what really matters the most in rural health. So my concerns are many. First of all, I call it the great lie that Congress is telling people that this is going to take care of those rural hospitals. Just shut up, JJ. We took away this money, but here you're getting it back. It's not going to supplant any of that money. They're for extra programs. We don't even know what the programs are at this point. I mean, we don't know what's been approved. We won't know.
Neither does the state. No one knows until December 31st. Correct.
That's my point. And so we don't even know. Now, things I was originally concerned with, what's the definition of rural? And I was very vocal because we have to guard the best interest of small rural hospitals. And there are big tertiary centers and big facilities, and I don't need you to comment, I don't need to get you in trouble, but there's big health systems that have small rural hospitals that they've bought. I don't want them to be included. I'm going to be selfish. At the end of the day, independent rural hospitals who are struggling, that don't belong to the big system, who's got billions of dollars in cash, I'm going to say I need to advocate for rural health. And so that was my take on, let's first define what is rural, and make sure that it gets to the people it needs to get to. And that was our first fight. I will tell you, and again, I'm not asking for commentary, but was not pleased that MDHHS, and I'm not here to beat them up, but that, the recommendations that were made by our committee, and the committee I'm referencing is the MHA, really weren't taken as serious as I wish they would have, because it was comprised of hospital leaders from throughout the state in every region, north, south, east, west. But again, even all those things aside, there's no guarantee that Michigan's going to get an approved application. And that would be devastating because you can't reapply. It's one and done. And so from your perspective, you've looked at, it's a 60-page report that the state put out. I've reviewed it for their application. What's encouraging there for you in some of those programs?
I like all four pillars.
Okay.
Another covered entity is a rural emergency hospital. There aren't, and
RH is very few.
Yeah, very few. And for those who don't know, that's an RH, a rural emergency hospital, is a hospital that has no longer having inpatient beds. Mm-hmm. You can keep a patient for 23 hours. And you want to have a really strong EMS system.
And I think it's just Sturgis, right?
It's just Sturgis, and there's maybe 40 or 50 in nationwide.
The country, right?
Yeah. And so they need help with their EHR. I don't think their EHR is functioning anymore. It was from like 2016.
Yeah.
Meditech, I believe, and there's no more patches, and they don't have the money to buy it. But there will be a fund that they'll be able to access to put in Epic.
I would love it too. I don't have Epic. And I have Epic in the clinic, but I have Evident CPSI for, which is for small hospitals on the inpatient side. And it's a bear.
Yeah.
And we were hopeful that some of that state funding that I had applied for under a grant, it wasn't approved, and then utilizing some of this money, because that's where we could see some real change impacted, because physicians communicating on EMRs, two different systems, come into OR, do surgery, the time wasted.
Right.
The data transfer, all of those things. So hopefully that's accepted as part of it. But I'm just very concerned, even if Michigan's going to get an application passed. So we'll know more.
Yeah, we'll know more, and I'm confident it will be passed. Your anxiety is what I was feeling back. We were in D.C. back in like June or July for a meeting, and we were meeting with Congressman Bergman's office, and we were meeting with his healthcare staffer.
Yeah.
And I was relaying the same concern. It's like it says in the statute that the CMS administrator, will fund no less than 25% of all the applications. I could be getting that wrong, but that's concerning.
It's very concerning.
Because to your earlier point, red, blue, all that.
Right.
And so I relayed that, and so that health staffer said, I'm going to go find out. And so he went to go talk to CMS, and they said, oh, no, everyone's going to get funded. So.
Okay, good.
Yeah.
All right.
But, everyone's.
Hopefully that comes to fruition.
Everyone's supposed to write to $200 million. And so some people, I think, will get more than $200 million.
True.
Some people will get less than $200 million.
Right.
I think it's going to depend on clearly your application,
the
strength of it, how well you've thought it through for a 5-year plan, But I think it's also has something to do with the population. Smaller states, do they really need the 200 million?
Right.
Right? You know what I'm saying?
Right.
So we'll see how this this
we'll
rolls
know
out.
here relatively soon, in a few weeks, what was accepted, right? Couple weeks?
15 days?
Is it 15 days?
What's today? Today's 16th?
2 weeks. 2 weeks.
Yeah.
So, John, we're facing a lot of headwinds. Payers changing their payment practices. You've got tough negotiations going on across the state right now with Blue Cross Blue Shield and, let's just say, for example, Corewell. And you're hearing horror stories. You're reading more about unionization, a lot of headwinds for hospitals. And then you have the federal government, which, did their number on us, which is stripping more revenue out of hospitals like Hillsdale. For me, I said earlier, $6 million. I don't recover $6 million overnight, but you have a couple options. As a rural hospital, we know since 2010, over 160 hospitals in this country have closed. And the majority of those, almost all of them, are rural hospitals. That's not even counting the ones that have affiliated and been bought out by big systems. But we believe in independence. We still do at Hillsdale. We believe in the autonomy of a local board. We believe in controlling healthcare because we can impact it the most locally, in part because we lack transportation to get patients out of here.
Right.
Public transportation does not exist in Hillsdale. There's no countywide transit. So we want to go into the backyards of these communities. That's why we started our mobile health van and done those type of things. But those are programs that are strict cost. Our OB program, all cost. Our inpatient psych unit, 10-bed, all cost. And so we as hospital executives have to make some tough decisions around the boardroom table to take these funds and strip our community hospitals. And with that knowledge is the understanding that millions of dollars is going to get stripped to take care of the most vulnerable in our community. The ones that, as a person of faith, that we're always going to have with us, the widows, the hungry, those that are in need. And so, John, I know that's a preamble to my question, but here we are faced with the heaviest of times, most significant headwinds, millions of dollars in cuts coming down to serve the same population with less reimbursement, and probably even more population that's going to be uninsured because of what's going to happen January 1 with, the tax credits that are going away. People can't afford some of these programs, so they're going to go uninsured. So now our bad debt shifts. So I've got higher bad debt. I've got Medicaid that's now going to go back to the days where it doesn't cover the cost. You have businesses and industries moving out of towns, so your commercial insurance is non-existent. This is a perfect storm for disaster. So I throw all that to say, at the Michigan Center, I think you talk about things that I talk about, which is growth, programs, sustainability. I'm going to ask you a loaded question. How are hospitals going to do it? What suggestions and initiatives to a CEO that's listening, not just in Michigan, this podcast is across the world, but across the country. What can health leaders do to combat this?
Well, first let me lead with something I think is important for everyone to recognize, and you talked about it earlier, about your personal experience using Medicaid as insurance, or the person at the Dollar General, or anyone. It's your neighbor, and it's really disappointing when our elected officials can profile people.
Yeah,
and it's not right that happens, because it's just not true.
It's true. You're right.
For the re-enrollment, we're starting to talk to folks like you, Ross Ramsey, Wendy Frush up at Munising. Mm-hmm. What? Because we got a year.
We do.
And it was on purpose that it starts on January 27 because the election's 2 months before. I think that was on purpose.
Mm-hmm. I agree.
We need to, if you have to re-enroll twice a year rather than once, it's going to take more than just your hospital, your billing department, your outreach worker, because people don't get sick on a cadence of every 6 months. No. So it's going to take bringing your community where the touch points are. So let me use Wendy as an example. We talked to her yesterday, the day before, and she's looking to, because she has like 600, we've identified 660 veterans in Alger County. Mm-hmm. So Jim's going to be working there. And then you have the Medicare issue too, with fraud, scams, that kind of stuff. And so people who are on Medicaid sometimes are very vulnerable to scams, and especially the veteran population, that happens too. And then you have Medicaid. And so we're trying to figure out, we're working with her, is like, how do you weave all that together? Where are the touch points where your enrollment can occur more than just in your hospital or clinic? Is it at Wheels on Meals? Is it with your EMS folks? So it's going to take that type of meshing of the fabric together to make sure that your community, if you want your citizens to stay on Medicaid, and you'll have to work hard to make that happen.
Yeah.
That's going to take thank God we've got 12 and a half months to put that together. And so
and as an example, at Hillsdale, I came immediately after that happened. I created what's called a Medicaid task force, and this is part of what our mobile health unit does. We'll go out and we've got certified credentialers now that will get people signed up for Medicaid and help them re-enroll, because we're talking about a population that sometimes moves a lot, and they may not get there.
Or they don't have access to Wi-Fi.
They don't have Wi-Fi.
Or a laptop.
In my own community here, I have a manager, senior leader, who doesn't even have access to internet.
We're talking rural.
This is a true story. This isn't make up. So they don't even have access online. And so that's part of this process.
Right. And so you have to identify those people. And when you mentioned the certified counselors for Medicaid enrollment, Ross has 2. And so
I have 1.
So we need to, and they need to be inside billing, and we're gonna have to find a mechanism to get you funding to get those, because it costs like $6,000 or something like that to get them certified.
Yeah.
And so we're looking at finding ways to help our independent hospitals with that, and our OTPs.
Yeah. Now we have a contract with the state, so they 50% they pay, and I pay 50% to have the Department of Health and Human Services worker full-time at my hospital, 40 hours a week.
That's
so what
great.
she'll do is she'll go into the ER and identify patients that don't have insurance. She'll go sign them up right there. Past discharge, so post hospital ER to the floor, she'll go up the next day and round on them and help them get their Medicaid. It's been a great program, but we're expanding that. So the state's paying 50%, I pay 50%. We'd love a second worker, but they don't have the resources for it. So we did it within our own staff. We're going to have to think like that to be able to keep these folks on Medicaid, which they deserve, and they'll qualify.
Well, we got to get you and Ross to talk, because that's what he's doing too. He has staff who's been trained.
Yep, and we're doing the same thing right now.
That's great.
We're getting them trained.
That's great.
But John, we're going to have to do that. We have to think non-traditional ways of how to take care of that population, and that's going to be critically important. So there's that, but sustainability, even beyond just the Medicaid piece of it. I mean, how are hospitals, what programs or outside of the Medicaid could CEOs launch to be able to keep their community hospital? What ideas would you give them? Collaborations, partnerships?
It's partnerships, I think, JJ. And I also think, MHA, all of the hospital associations, they're great.
They are.
They're great at advocacy, and we really need to take the stories that you were just describing need to be told to our elected officials.
That's right.
And they need to see, to see what is happening when you take that type of money out of a healthcare system. Yeah. Just pay us properly. And this really, I haven't fact-checked this, but I really wonder if this is the first time that a Congress has taken things away from people rather than enhancing their lives. I really wonder about it.
And the devastation will be as our community hospitals close. We're the economic engine for our community. You know that. Second largest employer.
All right.
Come on. We buy cars locally. We buy the groceries locally. We're, putting back tens of millions of dollars in the local economy, plus our community benefit. All of those things go away when your community hospital closes. And that's what's at risk.
Yeah, and it'll start with the closure of service lines.
It will. It starts that way.
Yeah.
OB first, then psych services, then outpatient things close.
There's not a rural CEO in America that ever wants to close
Never.
OB.
Never.
Because it's the happiest spot in the whole hospital.
My goodness, you got chimes going off when the baby's born.
Exactly.
Come on. Lullabies are playing.
Yeah.
You don't want to do that. But you also have to remember you want to be there for those patients coming in with heart attack and stroke. Those are all very important things as well, and you have to balance it.
Yeah, it will. Your ED use is going to start to climb again.
It's gonna be back to where it was 15 years ago. We had 30,000 in the ER. Now we have 20,000 a year in the ER, And I don't want to go back to the days of 30,000, but that's where we're going to head.
And it's expensive.
Yeah.
EDs are expensive.
Yeah. So it's going to be a challenge. We've got all these things, and when we look at it, it's not going to be the government that fix it immediately. Programs, partnerships, those are very important. So if someone's listening today, John, and wants access to these programs, you said every state's got an office. They should really reach out to their state associations, correct, for help. There's no reason to be an island.
No, a state office can put you in contact with other people. They can help. We're conveners. Yeah. We're good at bringing people together. There's nothing more powerful for us than having the quality managers of 35 critical access hospitals meet on a quarterly basis. And they're not all CAHs, JJ. We have a couple rural PPS, and so I extend that to you too.
Thank you. Yeah.
To have your quality manager participate.
Yeah.
EMS, having them convene. There's a lot of power in having people talk about what's good. And so, we're going to make sure that you and Ross talk and Wendy about how to make, the consultants on the Medicaid side make sure that there's community involvement. And I really think that communities need to hear that you guys are in danger. Mm-hmm. Because I don't know if that's ringing through the communities yet.
Well, what they hear is the opposite, John. They hear hospitals are going to be fine. They overcharge. We've got all this garbage we're dealing with now at the state level with Speaker Hall, who's saying that, hospitals are overcharging, that there needs to be transparency and all kinds of words such as waste, fraud, and abuse. But let me tell you something. When seconds count, your local hospital can save lives, and we're doing it every day. My wife included. My wife had a stroke, an ocular stroke, young lady, ocular stroke. Had we not had this hospital here, my wife would be blind. Now she has partial, blindness and almost completely blind in one eye. But at the end of the day, we had an ophthalmologist. How rare is that? Who's on staff, and he was working that day, did an old technique to rub her eye. And had we not stabilized her with the TPA and got her to Borges Hospital, I don't know what would have happened to her. But that's one case of many.
Yeah.
And I have transportation. I have access, right? And just imagine those families that don't. This is what we're talking about. This is a difference between life and death. We're politics today, what we're dealing with, just shaping our future and using words like fraud, waste, and abuse is so insensitive. It's insulting to hospital work that we're doing in the trenches every day. So continue the fight, John, for us, if you would, as you lift your voice. I was out 4 years ago, and I heard another Godfather story. So I'm out and I'm meeting Tom Morris, and John, I'm Barnas, there's that name again. I'm like, yes, I do. And you're well known. And you actually had Tom, I believe, here up in the UP this year.
2 years ago.
2 years ago.
Yep.
And I remember that. And it's pretty amazing when you go to Washington, D.C. and they know your name. And they did. And it's because of the work that you're doing. And it's a lot of heart, soul. God knows you're not doing it to get rich. You're in the public safety or public health arena, and it's kind of like public safety officials. You're doing it because it's passion and care, and you see it in your face and the work that your staff do every day. I mean, they were so excited when they came down to our hospital a few weeks ago. You just feel the excitement, and we need a lot more of that in today's very negative world. So keep up the great work, John. We appreciate what the center's doing.
Well, thank you for the kind words, and I'm sure my staff will listen to this, and they're great.
They are great.
I just turn them loose, give them resources, stay in the guardrails, keep moving forward, and thanks to you, JJ, for your leadership in this community. You've had it's been a long road, and you're still smiling.
Yeah, well. It's been a unique challenge.
Yeah, and to all the rural hospital CEOs and all the rural providers out there, thanks for everything you do. We recognize your work, so thanks.
John, it was, I'll end with a story. It was shortly after President Bush left office, I was in Chicago. Scott Becker, who's been on this program many times. Scott Becker was with GW, and I remember being in the room, and one of the reporters was really harassing President Bush and said, really gave him a hard time about what had happened in the Middle East. And finally, President stopped her. He said, listen, history's going to judge me, not you. And I remember that phraseology very well. And I look at this issue with the one big, beautiful bill and what we're fighting. History will judge us. And you know what? We're on the right side of history. I'm a firm believer of it. I believe we're on the right side. And I think when the story is told, if we don't lift our voices now and fight, John, we're going to look back and say we wish we would have. I think every breath we're given, every opportunity, and a lot of these are my friends who did this. And we have to stand for what is right. Doesn't mean that I disagree on other issues socially or economically. On this particular issue, I lived it, and I know what is right. I see the faces every day. I talk to the pastor of the church. I talk to the attendant at the gas station and the lady at Dollar General, who I see her face right now as I think of her, telling her story. It's scary, and I think we're on the right side of history. So keep fighting the great fight that you're fighting, John.
I agree. Fist bump, man.
There we go, man. Good job. Before we close today on this episode, and we've done this now with the rebrand of our podcast, we asked for a rural health recommendation. So we have CEOs and C-suite that are listening to this program throughout the country, and some are brand new to their job. And what a time to get in healthcare. But, some sage advice you could give to someone who's listening today. Maybe it's a tip. Maybe it's an encouragement. Someone who just needs, we need a little more positivity. What one piece of advice, rule recommendation would you give to a new leader, or maybe it's a seasoned leader who's just struggling? They're frustrated.
Well, I'm going to make this situational.
Please.
Because you have a large, diverse audience. And so for anyone in leadership, the first thing to do is become involved in your community. Listen. Listen first. Always listen. Be humble. Think about others.
Absolutely.
And make the right decisions. It's leadership. Leadership doesn't have to be charismatic. You just need to be humble, and you need to listen and do the right thing. Yeah. Just do the right thing. And then for people who are not in healthcare but care about their community, find a spot in your community to volunteer.
That's right.
It can be at the school. It could be at the Meals on Wheels. It could be at the hospital, at the clinic. It could be at Parks and Rec.
Could be.
It could be anything to help beautify, uplift your community. It's your community, so get involved.
It's a great suggestion. And if we had a little bit more of that, this world would look a little different, wouldn't it?
I think so.
I agree. John Barnas, man, myth, not a legend. I tell you what, he is a doer, and he doesn't sit on his laurels. He's out there in the field every day. You visited our hospital numerous times. You're from the UP down to the southern tip. And everywhere in between, and then flying to Washington to advocate. You spent a couple times out there this year.
2 or 3, yeah.
It's been great to have you in the studio today, John.
Thanks, JJ.
Keep up the great work. Thank you to our listeners for tuning in to Rural Health Today. Catch our next segment, Rural Health News, to stay up to date on the current state of rural health every Monday, wherever you get your podcast. Don't forget to check out our latest updates and resources from Rural Health Today at ruralhealthtoday.com. And make sure you've subscribed to the show so you never miss an episode. Until next time, remember the power of rural.
Thank you for listening to another episode of Rural Health Today, the podcast where we connect you to what really matters in rural health. Rural Health Today is a production of Hillsdale Hospital in Hillsdale, Michigan, and a member of the Health Podcast Network. Our host is JJ Hodshire, our producer is Kirsten Newlon, and our audio engineer is Kenji Ulmer. Special thanks to our guests for sharing their expertise on the show, and also to the Hillsdale Hospital marketing team. If you want to submit a question for us to answer on the podcast or learn more about Rural Health Today, visit ruralhealthtoday.com.